Okay, then. Right, bola. Okay. Okay.
Good evening, good afternoon, everyone, once again. So, today we are going to start with the second part of our immunization and nephrology discussion. And once again, we have Dr. Prithiviraj sir with us here today to discuss the remaining part of the session, which was conducted 2 days back. Thank you for very good feedback from all students. And we are very happy that these sessions are helping you all for your exam. And I hope that the today's session also will be like helping you all. So I kindly request you all to stay in the live so that it will be like helping you to ask your doubts in the live itself. And if at all some part of the session you missed it, don't worry, it will be like there in the YouTube. Thank you so much once again. So I would like to hand over the session to sir.
Okay. Right. Okay. Good afternoon to one and all present here. So today we are continuing our session, which we did on Friday on nephrology and immunization. Before going to the immunization proper, there are few questions which I saw in Tamil Nadu University exams, which were took. We will be discussing one or two questions in nephrology, after which we'll go for immunization. In immunization, what we are going to cover, as per according to two things, that is your OP Guide 2023 edition, that is your 10th edition OP Guide. Those people who are preparing from your 9th edition, some people are also preparing from 8th edition. Please beware of the changes because recent changes have been done in the year of 2021-22 by your IAP chapter, vaccination chapter. So there are few recommendations, few changes in the vaccine names, vaccine drug dosage, and also there are few recent advances in vaccination, and there are few recent recommendations that was still in 2023 end. There was a recommendation. So you should be beware of all these changes because these are the potential questions that could arise in your theory Viva questions. And also, in practical Viva table, one of your table is vaccination. So you should know in and out of two vaccination table, sorry, vaccination schedule that is followed in our country. That is your IAP as well as your national immunization schedule. So we will be discussing briefly about each thing and each vaccination importance, what are the dose, what is the route, what are the recommendation in both your IAP as well as NIS. And when I will be discussing each and every vaccination. Now, normally I am planning to discuss about the important 10 to 12 vaccines which are being kept in your Viva OK table as well as been asked in your theory examination. So you should know in and out of that vaccine, the dose, route, and schedule, what are the contraindication, what are the adverse reactions, and also what a catch-up vaccination, which is frequently asked in your theory, as well as many people ask to deal that thing same about that same in our class. So let's start the class proper. So before going to the immunization, as I said, there are not two questions which I left to base the last class because of that overshooting of time. So one is your posterior urethral wall. Why this is important? Because there are few when you go for any delivery or any chapter, even in a delivery, you are seeing few babies, and there are few antenatal scan reports which tell about the antenatal hydronephrosis. What is this hydronephrosis? So you have dealt this mm, before. If you see any antenatal scan in your fetal scan, when you do at the 18 to 20 weeks of anomaly scan, you will see some important major anomalies that has to be ruled out. One of the major anomalies that has to be ruled out your hydronephrosis. So hydronephrosis is nothing but the swelling of the kidney. So hydro means collection of water, nephrosis is your kidney. So swelling of kidney. It could happen because of any reason. So one of the most common reason is your posterior urethral wall. This posterior urethral wall is seen only in male children because this wall is seen at the urethra, prosthetic urethra at the level of your vermentum. What is the vermentum? Vermentum is seen in which where it is a ridge seen in your urethra where your seminal vesicle opens up. So seminal vesicles are seen only in male children. So these are more commonly seen in a male child. So just given a few important points, silent features, and how to diagnose and what is the treatment. Simple. So this was asked as a 5 mark question in your university, 2017, 2018 of Tamil Nadu MGR University and Kerala University. They asked one or two few 1 mark question as well as a 5 mark question. Like one is question is name two clinical signs of PUV, that is posterior urethral wall in an infant. Give one modality of investigation and diagnostic find. Next, so posterior urethral wall per se, the other name is congenital obstructive posterior urethral membrane, and it's also said that it's a severe obstructive uropathy that is seen in male children, and this is the important thing. The most common cause of, so one of your viva question or one of your multiple choice question, most common cause of lower urinary tract obstruction in the male child, the answer is posterior urethral wall. Right? You should know this posterior urethral wall. So posterior urethral wall is the most common cause of lower urinary tract obstruction in the male child. So let's go by the question. So what is this posterior urethral wall? So see this diagram. So you are having a vermontum, right? This is vermontum. Sorry, on this. Okay. This is vermontum. So this is here differentiating point between what? It's your junction of anterior and posterior urethra. So anterior as well as the posterior urethra will be differentiated by vermentum because the anterior is urethra. Like this is your urethra, right? This is your vermentum point. This is your anterior and this is posterior. So this point is your vermentum. So what happened? That's a tissue that what this is a tissue that grows from this vermentum to the like this. So you will have this kind of tissue extension. A tissue leaflet that fans from the vermentum to the external urinary sphincter, which shown in this picture. So this green color highlighted point, right? This is your posterior urethral wall. So it's like a membrane. That's the reason why the name is the other name for your posterior urethral wall is congenital obstructing posterior urethral membrane. Now, so what does this cause? So systematically, if you go, what is the consequences of PUV, that is posterior urethral wall? One of the complication, as I said, when this posterior urethral wall is formed in the child, so normally the urine has to flow from the urethra, external urinary sphincter, and then the penile urethra, and it comes out. But because of this membrane, the space has been reduced, so urine cannot pass. So this is present in utero itself. So I am talking about in utero. So posterior urethral wall is an anomaly that is present in utero. As a result, the fetal urine will never pass. The child will not pass urine. And as you know, after 20 weeks of gestation, the fetal urine plays a major role in the formation of amniotic fluid. So after 20 weeks, the amniotic fluid, the 80% of composition is your fetal urine. So from 20 weeks onwards, the fetal urine has to contribute for your amniotic fluid. When a child is having this PUV at early as 10 or 12 weeks of gestation, the urine will not come out. So these children who are so that's a catch. Any child who is having a PUV less than 18 weeks of gestation, then they will have a anhydromias. So the most common finding you will be seen in your any case if any child who is having a PUV, if we diagnose antenatally and postnatal, simple. So I am going. So this is two things we have to discuss. But before that, you should know what is the consequences of PUV. So PUV, what it does when the posterior urethral wall is present. So the urine cannot pass from bladder to the urethra. So from posterior prostatic urethra to the final urethra. So what happened? The urethra, the bladder gets started to distend. So the child will have a palpable bladder. Once bladder is occupied, has been occupied maximum amount, then what happened? Then the urine get reflux into the urethra. So you'll have a dilated ureters, after which the kidney get affected. So PUV will always cause bilateral hydronephrosis. Yes. So one thing, kidney get affected, bilateral hydronephrosis. Second thing, as I said, the bladder get distended. So as I said, the bladder muscular hypertrophy will happen. So there will be bladder outlet obstruction because that's a bladder outlet obstruction here. So this is a bladder outlet. So that's obstruction. So what the bladder outlet will do? As a result, what happened? There will be a dilatation of prostatic ureter. What I showed there will be bladder muscular hypertrophy. And then in the cases, and kidneys are going to be involved. Most of the time, when the kidneys involved severely affected, then the child will have a renal insufficiency, and it has been seen as chronic kidney disease, and ESRD is seen in 30% of cases. And this child, as I said, there will be a regurgitation. That's a reflux of urine from the bladder into the ureter. You know why? Because the bladder gets distended with urine. It has achieved reached this maximum capacity to hold the urine. Now that the urine has to go outside, either the bladder has to rupture or else it has to go via the ureter. So this is a VUR, vesicoureteral reflux. So most of this antenatal hydronephrosis, baby PUV are associated with your vesicoureteral reflux, and they will have a recurrent URT infection. So these are the consequences of your posterior uretral wall. So posterior uretral wall, as say, there is an obstruction in your urethra, posterior urethra. Like, what of this obstruction? What is this? Your bladder get distended. When the bladder is getting distended, the reflux will go in both sides. The urethra will distended. Then your kidney will be distended. Your kidney will be distended. We have multiple like this. Your bladder. So you know that this will also get distended like this. Then your bladder get distended. This will also get distended. This is your posterior urethral wall. So in simple, this is posterior urethral wall because that's a back flush of your urines. The bladder gets distended. Bladder distension called as megacystitis, mega bladder or megacystitis, cystis. Then your hydroureter, bilateral hydroureter, and you have a severe grade 3, grade 4 hydronephrosis. Your grade 3, this grading you will be learning in your, if you are reading surgery urology, that's an SFU grading for hydronephrosis, antenatal hydronephrosis, that is Society of Fetal Urology. They give an hydronephrosis. According to this all get dilated as a result of your PUV. So with this simple diagram, you can tell the child maybe, so this is the consequences of a PUV. And as I say, because there's a reflex, VUR reflex like this, will have a reflex. Yeah, so they're more prone for VUR, and they have a tendency for having a recurrent urinary tract infection also. So this is the posterior urethral wall. So posterior urethral wall, how do you differentiate and in both antenatal and postnatal? In antenatal, if you go a second trimester scan, when you do a second trimester scan, you will see this PUV. Per se, you cannot see the fetal bladder. What are the things which tells that the child may have a PU. First, the child must be a male child. First thing, you will not disclose the gender. As per the act, you cannot disclose the gender, but you can find it out that it's a male child by female child, because the sex differentiation of male and female by 10 weeks of gestation itself, the doctor uh, can identify the sex. It is easy to identify. It's based upon the character which we see to tell it's a male or female child. As a doctor, you can know it, but you cannot disclose it. Simple. So one, sorry, it's a female. It's a male child. First, it should be a male child. Then the bladder must be visualized. You'll have the bladder will be more than 7 mm. Normal size is less than 7 mm. If it's more than 7 mm, we say that the bladder is normal. And the thickness of the bladder will be more. It will be 3 mm, more than 3 mm. And then you have a prostatic ureter dilatation. Now, when the bladder as well as your prostatic ureter get dilated, it gives a sign known as, anyone can tell what is the sign called as? What is a sign that is known because of the both dilatation of the bladder and your prostatic urethra? Anyone? It is known as keyhole sign. It looks as a keyhole, right? It's a keyhole sign. So how can I say that it's a keyhole sign? How to wait? Show that picture. Yes, this is a keyhole sign. Okay. Can you see this? Yeah, exactly. See, this image will tell. What is this? This is your bladder, right? This is your bladder. We'll download this. Hmm. So, see, so we have a bladder here. So this is bladder. This is dilated bladder. It should be more than 7 mm. And the urethra must be dilated. Any dilatation of urethra, that's no any significant value to tell. Any dilation of urethra is significant. More than 7 mm of size of bladder, and thickness of the bladder wall will be more than 3 mm. If all these three is present and with bilateral hydronephrosis, these three factors. So one is bladder is distended more than 7 mm, thickness of the bladder more than 3 mm, any visualization of posterior urethra, and bilateral grade 3 to 4, whatever grade hydronephrosis present in a male child, always suspect PUB, posterior urethral wall should be suspected. This is a tip. It's a classical USG finding, antenatal USG finding of posterior urethral wall. Okay, so simple. So what is the management? So this is antenatal. Postnatally, the child will present with decreased urine output, palpable bladder, palpable kidney, irritability, and they will not pass. So there will be oliguria plus palpable bladder, bilateral renal mass, and other clinical features. These are the three features you will see in a postnatal hydronephrosis. Sorry, in postnatal cause of posterior urethral wall, because the urine they will pass, they will oliguria will be present, or they will have abnormal urine stream followed by palpable bladder and bilateral renal mass will be palpable. So in a child, and there will be a history of when you go see the antenatal report, you can see this posterior urethral wall may be present. So what is the management? If the child is term baby and the child have no other comorbidities, because sometimes it is associated with some syndromes. If there is no syndrome association and child is hemodynamically stable and everything is normal, it's not a preterm baby, it's a term baby, then you directly go for fulguration of the wall. Fulguration of the wall is a procedure of choice. Either do a laser or a electrocautery. You can do the fulguration of the wall. If the child is not unstable term baby or a preterm baby, you cannot do a surgery, and then a severe hydronephrosis is present, then you have to decompress it. The decompression is by doing vesicotomy. Right? You have to puncture the bladder and you have to remove the urine so that you can decompress uh, your decompose the uh, kidney, because kidney has been completely filled with your urine. Because to take out that urine, you have to do the vesicotomy and then you have to assess. If your assessment, the child is after that the child stabilized, then you go for the fulguration of the wall. But even after that, the child is not improving, or when you are removing the urine, you see the pus, gross pyuria, there is no improvement, you go for eye urinary diversion. Okay, so this is a in a nutshell. You are seeing a PUD, a term baby, hemodynamically stable. Do fulguration of wall. Either electrocautery or second, whereby laser. This is the treatment. This is the treatment of choice. If anyone asks what is the treatment of choice, electrocautery, that is fulguration of, right? So if the child is not that much great, the child is preterm or hemodynamically unstable, then what you have to do? You have to do a vesicotomy. You have to puncture the bladder and you have to decompress the kidney and bladder, or else they will rupture kidney and bladder. After that, you have to see whether there's a gross pyuria and the improvement in the condition. If after the both of negative improvement is there and there's no gross pyuria, then go for the say fulguration once the child is stable. But instead of that, if the child is having pyuria and there's no improvement, then there's no other way, you go for eye urinary diversion, which you will be reading in your urology of your surgery, or what is eye urinary diversion. So this is in a nutshell. I talk about the posterior lateral wall, which was an important 5 mark question, and as a resident, as a graduate, should know about this, because surgery also it is an important question, 5 mark question, and in pediatric also they have been asked this question. So that's why I elaborately detailed about this posterior lateral wall, right? Okay. So next, we will directly go to the immunization, right? So immunology is a major chunk, as it's previously discussed, because your paper every year 1 or 2 question, 1 question of your 2 mark question, as well as 5 question will be of this immunization. Since from this year it's 100 mark, so sure shot one of your 8 mark question, or one or two of your 4 mark question or 5 mark question will be coming from the immunization. And in 1 mark question, which is about 10 question, they can ask any 2 or 3 questions related to immunization, because immunization carries very important weightage in the pediatrics. So just we will discuss the relevant definition and concept before going to the each vaccine. So what does so you have already read this in your you have already read this. I guess you have read it in immunology of your microbiology, but just to get warm up, what is active immunity? So the ability of the immune system to mount immune response, the ability of the body to mount immune response to an antigen. Either it is an active, uh, either by a natural infection or by the vaccination, right? That is your active immunity. So this is the immunity, it is your immunity system status. The status of the immune system can be testified by your active immunity. So what that active immunity define? What does it mean? The ability of the immune system to mount immune response against the antigen. Now, this antigen, either you be going with a vaccine, that is your, or natural infection. Okay, so vaccine and natural infection. What is passive immunity? In passive immunity, the antibodies, see, here you are training your immune system. So the immune system will catch hold of these antigens, and by your antigen presenting cells, dendritic cells, that in turn come in contact with your T helper cells. Now, these T helper cells will help your B cell to proliferate, and they mount a response. They produce immunoglobulins, and these immunoglobulins will destroy that particular antibody and particular antigen causing microbes. While during that process itself, T helper cell divide plasma B cells into plasma cells and memory cells. Now, these memory cells will remember this event. So, whenever the same antigen or the same microorganism comes again in the body, they will produce an immune response as soon as they come in contact with the antigen. So they will have an high amount of IgG and IgM antibody, and they will have a permanent response to it. So always a primary immune response, that the primary immune response, that is a primary exposure, will, what the primary immune exposure will do? The primary immune exposure, that is the first contact with that particular antigen, will sensitize your body. Sensitize their body to that particular antigen. It takes at least 3 to 14 days to do that. And most of the time it's an IgM type. And so it's not going to stay for long. So it wanes off easily. But in this process, it has already formed the memory B cells. This is very important. And this memory B cells are nothing but your germinal center. These are your germinal center. All your, whatever germinal center you see in the lymph nodes, in your spleen, they are going to stay there. Okay. So someone asks what is fulguration. I will discuss at last of the at the end of the session. While discussing, I will tell about the fulguration. Okay. So memory B cells, right? So in memory B cells, this memory B cells are going to be seen in your germinal center. Where is the germinal center? Is lymph nodes and spleen, right? Now, this memory B cells are going to stay. Whenever you come in contact with same antigen after 2 months or 3 months, now the body is trained for that antigen. So once the antigen presenting cells catch hold of that antigen and present it to the T helper cell, now T helper cells recognize it because it has been predisposed. Now directly it will activate the memory cell. It will activate the memory cell directly. Sorry, that is not. So activate the memory cell directly. And now what does this memory cell will do? Now this will produce the huge amount of, because highly specific antibody. Now this is highly specific. Because initially, the IgM antibody was produced was non-specific. Because one thing, the non-specificity is because it's a new antigen, so the body will train itself by producing a lot of chronicle antibody. So one of the antibody to which this antigen will respond, that will be that particular cell will be converted to the memory B cell, because that memory B cell is the one which produces the specific antibody that targets for that antigen. So once the baby or the child or the adolescent, whoever get re-exposed with the same particular antigen, they will mount an immune specific. That is your antigen specific immunoglobulins. High specificity IgM and IgG will be produced by the memory cell, and it will rapidly clear up that antigen. So it takes at least it's just within 3 days. Initial primary exposure takes at least 14 days to respond to that particular antigen. But the same antigen, if it comes for as a secondary exposure, that is secondary exposure, it mount an tremendous immune response, highly specific IgM, IgG will be produced, and it will clear off that infection from the body within 3 days. That's the reason why the vaccination is given. Vaccination is not the thing which will prevent from the infection. Actually, it will train your body so that when the actual infection comes in play, the body will recognize that infection and it will produce an highly specific antibody within 3 days and clear off the infection. So the actual problem like complication related to that particular infection, morbidity related to the particular infection, mortality, everything comes down. So this is the principle of vaccination. So now you know what is vaccination. Vaccination is nothing but that will never, no vaccination will prevent the disease. Mind you, no vaccination will prevent the disease. You will get the disease. You will get the infection. It will prevent the disease, not the infection. Sorry, I told in a wrong way. Vaccination will prevent the infection. Sorry, it will prevent the disease, not the infection. Infection will occur, but the severity will be reduced, or it will be asymptomatic. Simple. Okay. So this is about the active immunity. What about passive immunity? As I said, so body has to, training the body. The body has to produce memory B cell. Then the immunoglobulins will be produced. Then you are able you will be attacking the real crime, criminal here. That's your antigen. But what about this? What passive immunity? We are going to bypass that pathway. I don't have that much time because in immunocompromised, high risk patients, special group, mostly your children, for them it takes more time to mount that immune response. They may even take 28 days. I don't have that much time, or the child will die because of that illness. So in that way, we came with a concept called as passive immunity. So in passive immunity, what we do? In passive immunity, either already preformed antibodies are injected into the body. Simple. Preformed antibodies are injected into the child, adult, or the individual. It could be your immunoglobulin or antiserum. Okay. Immunoglobulin is what does immunoglobulin? It's nothing but it's a peptide. It's a globin peptide. Protein, globulin product 17, which produced by your plasma cells. What is this plasma cell? Anyone can tell what is plasma cells in the chat box? Plasma cells are derived from what? T cell or B cells? Anyone? Plasma cells are derived from where? Yes. It's derived from a B cells. So when B cells get activated, it get converted to plasma cells, and some of them will get activated to a memory B cells. And now these memory B cells will go and stored in your, as I said previously, the germinal center. But what we are doing, these plasma cells will produce the immunoglobulins, right? So I am directly giving this stuff instead of going to this long step. So this step has been diverted. Only I am giving immunoglobulin. What about the antisera? It is a polyclonal antibodies, and it is from the serum of the patient. For example, you see what is hepatitis B. These hepatitis B immunoglobulins are produced from antisera. Got the hepatitis B immunoglobulins are produced from an antisera because the patient was already get sensitized post infection. They will have a amount of antibodies. From that antibodies, we are taking out and we are preparing, we are sterilizing it, and we are giving to the patient. That is antisera. For example, hepatitis B, what we give the passive immunization. So immunization and vaccination, similar concept. Immunization is the by you are stimulating the immune system by providing vaccination. That vaccine could be an active vaccination or passive vaccination. What is this active vaccination? The active vaccination goes with the your vaccine, giving vaccine. Whereas a passive vaccination in the favor is go in favor of your anticellular immunoglobulin. And this vaccine can induce three things. Vaccine either target your cell-mediated immunity, vaccine can target your humoral-mediated immunity, vaccine can target both. Now tell me, all the vaccine which we are using right now target what? Whether it's cell-mediated immunity or humoral-mediated immunity or both. Most of the vaccination which we are using, it targets both. Give an example that only target cell-mediated immunity. Anyone? Give an example that target only the cell-mediated immunity. Anyone? It's where BCG. Name the vaccine which target only humoral. These are few exception. I'm telling this point because this can be a potential 1 mark MCQ in your university 1 mark question. So since from this batch you are having 1 mark, they will target this question which is very exceptional one. So exceptional ones should be remembered because they are the potential target for your one-liner and 1 mark. So which vaccine is for humoral mediated immunity? It's your Hemophilus B vaccine, right? Now, what is the immunogenicity? Immunogenicity is nothing but the ability of the antigen. It's about the antigen. I'm not talking about the body. The ability of the antigen to mount. The ability of the antigen to mount adequate immune response either by producing antibody or cell-mediated response. The antibody that is produced should be in the seroproductive level. What is seroconversion? Zero, I will see. So when you see any antigen that has ability to produce an adequate immune response, then you say that that antigen, that vaccine is immunogenic. So simple as so immunogenicity is nothing but the ability of the antigen to mount adequate immune response either by increasing the antibody titer in the body or an adequate CM response. The cell-mediated immune response is your T cell response. This antibody level should be in the seroprotection range. What is the seroprotection range? The reason this seroprotection range is the say minimum level of antibody that protect that individual from the infection, from the disease, that protect that the suspectable individual from the disease and infection or disease. That level is known as seroprotective level. Each vaccine for every disease, for very vaccine, before giving a booster dose, for example, hepatitis B, because hepatitis B is the most common vaccination that is provided to all healthcare workers. For every first year MBBS student before joining the college, all have to be mandatorily vaccinated for the hepatitis B at the age of 0 and at the 1 and 6 months. Okay, 0, 1 and 6 months you have to be vaccinated with that. So this hepatitis B before giving, if a person he or she is saying that they have been previously vaccinated, then whether to give the dose or not is determined by your seroconversion rate. The seroprotection titer, if it's more than 10 international unit per ml, 10 international unit per ml, then that is a seroprotective level is that. So there is no need of vaccinating that particular individual. Simple. So what about seroconversion? That is the from negative to positive. So that seroconversion is the when you have the antibody negative status to the status of antibody positive. Changing the status from zero antibody to that particular infection to presence of significant and not significant, just antibodies. Conversion from an antibody negative status to an antibody positive status for any particular infection is known as seroconversion. Right? Now, if this just an antibody, it's not to be mandated that should be to a level that protects from your infection. But antibody plus, if can detect a minimum you are detecting an antibody for that particular antigen or for that particular disease itself, till that the patient is seroconverted. But for this antibody to protect that person from the recurrent infection or from that particular disease, protect the person from the disease in future, then you have to see what it should be a minimum level. That minimum level is known as seroproductive titer. I guess everyone getting it. So any person, if you have been negative for any infection, that infection attacks you, the body mount and response produce an antibody. So your state from an antibody negative state to an antibody positive state is known as seroconversion. But that is not enough to protect you from the further infection. So I will come to that question. Oral polio virus as a target only cell-mediated immunity. Yeah, that could be, but that because polio vaccine is not only oral polio. Why the reason I didn't give the oral polio virus? Because oral polio virus doesn't go for T cell. So polio is an intracellular or extracellular organism. First, you should know that one thing. And we have two components in oral polio virus: oral and inactivated. Oral and inactivated will act, inactivated most commonly will sense your humoral, and oral will also have cell-mediated immunity, but the cell-mediated immunity also helps in your production of your immunity towards humoral immunity. Humoral immunity is also get activated by helping in the production of the IgA. When the immunoglobulin A is produced, it itself tells that your humoral immunity is also getting involved. That's the reason why OPV is not just an cell mediated; it's also cell mediated and cell as well as your humoral mediated. We will discuss about that. So this is the seroconversion. So seroconversion or seroconversion is nothing but antibody negative to an antibody positive titer. When it comes to a minimum level, that is a seroprotective when to the minimum level to protect you from that infection, then it's known as seroprotective titer. Again, you understand this concept. Next, you go for protective efficacy and vaccination. What is this protective efficacy? Now, this is known as protective efficacy. Protective efficacy, right? The protective efficacy is nothing but the number of people get disease who are unvaccinated minus number of people get disease who are vaccinated for that disease for that particular infection who are vaccinated and divided by number of people get disease. The denominator is who are unvaccinated, not vaccinated, who are unvaccinated into 100. When you do this, you will get some value. So The efficacy of vaccine is determined if it is more than 90 or some, sorry. Okay, there is no particular. So how comes the values is determined? For example, taking an example per se, I'm taking an example. So, for example, a person is vaccinated for so-called diphtheria, DPT vaccine. That few percent. That, for example, 50% plus 50%. That's totally 100%. I am saying that this 50% are vaccinated and this 50% are not vaccinated, unvaccinated. Now, out of this 50%, there was an epidemic. There was a diphtheria transmission was present. Only 5 people get. In fact, out of 50 who are vaccinated, only 5 got diphtheria. Whereas out of 50, only 5 people didn't get diphtheria. Whereas 45 people get diphtheria. So those who got diphtheria are them. They are least vaccinated, they are non-vaccinated. So how this number of people get vaccinated or unvaccinated is 45. Number of people got disease who are vaccinated just 5. And number of people get disease who are unvaccinated. That's 45 into 100. What you get? 40 by 45 into 100. Right? You go calculation by 8. This is 9. This will go 800 by 9. So you go for calculation, I guess 70 to 90. So you get 80. So mostly they are 98%. Sorry, not 80, sorry. 88. Around 88% of protection is given. So in this way, protection, this is the way you can calculate efficacy of the person. So 88% of it protect the patient, protect the individual who have been vaccinated. So 88% of individual has been protected from the particular disease. So this is the protective efficacy. What's about the vaccine efficacy? Similar, vaccine efficacy is nothing but a protective efficacy. The ability of the vaccine to protect that particular population from that disease is known as vaccine efficacy. Always know that vaccine efficacy is always lesser than the protective efficacy. So protective efficacy, what you calculate for the particular vaccine, in reality will never happen because there are few problems with associated with the delivery of the vaccine potency, till the site where the vaccine is given, the importance of cold chain. So everything get play an important role to keep that same protective efficacy that you tested in lab to be reflected in the field, that is in the population, right? And the vaccine efficacy for particular disease, which are the diseases which have low vaccine efficacy? If you ask, any vaccine that only target only the disease, not the infection. One. And any vaccine already have a low protective efficacy in the lab. And third one is when the reservoir, the host is not reservoir of it's not an human being has no play in a reservoir. So that is the thing. We have a low vaccine efficacy. One, the vaccine that only target the disease, the vaccine that already have a low protective efficacy in the lab, and the third one is the vaccine which where for the particular infection there is no human vector, sorry, human host. This is your DPT. So your DPT is the pneumonia. D is for diphtheria. We don't target infection there. We target disease. Low protective pertussis have a very low protective efficacy. Tetanus, tetanus has no human host. So these are the example for the low vaccine efficacy. So they can ask this question. So what is the herd immunity? What is herd effect? What is okay? So let's see. For a particular your bunch of population is there. I'm just explaining the concept. Remembering the concept is more important rather than mugging up, because you can do that by reading, but you should know why you are mugging up. So if you know the concept, that you can easily remember it. Simple. So if you're taking 100 bunch of people and you're vaccinating 85 of amount of these people out of 100, whereas 25 remain unvaccinated. Got it? So I'm vaccinating just these people, right? Now what happens when and you're vaccinating everyone on simultaneously? So when you vaccinate a bunch of people in a particular population simultaneously, it would break that transmission chain. You know the transmission chain in our community medicine? That's the transmission chain in epidemiology. So now when you are breaking this transmission chain, the particular pathogen cannot now replicate because the transmission chain is broken down. As a result, the person who are not even vaccinated also get benefited from this. So they are getting protection because of the other person, because the transmission chain has been broken up. So this is known as herd effect. So what is herd effect? Simultaneous vaccination of the population was susceptible to that particular disease will break the transmission cycle of that transmission cycle of that disease, of that particular infection, or the infection, in turn protects the unimmunized people who are also suspected for that. This is known as herd effect. Can anyone name that program where this effect is being used? Anyone? I just want someone to type it. Since it's an interactive session, I just want it should be interactive, or else just I am talking. That's no scope. What is the program which the government of India uses every year with the principle of this herd effect? Any answer? Raghunandan, you can try. I guess everyone is silent. Yeah, exactly, right. It's polio. So what's that program called as? What's the program called as? It's a pulse polio program. So pulse polio program utilizes the same principle of herd effect. So pulse polio program is carried out by our Indian government every year, where all the children below age of below the age of 5 years are vaccinated or given oral polio virus, irrespective of the previous vaccination. This is very important. Whether they have been completed the vaccination, they have already received OPV, I don't care. Just I am going to give this to all 5-year-old child. So this given herd effect, because polio spread from fecal-oral transmission. It's a fecal-oral transmission. So fecal-oral transmission, when you are going to give an oral polio virus, polio vaccine, now this polio vaccine will prevent that transmission. The fecal oral, because there is no virus, so there's no fecal way. So from the fecal, the contact, the other person who don't get vaccinated will get protected from this. So this is pulse polio program, which affect the herd immune effect. So what about the herd immunity? What is the herd immunity? So that is simple. The effect when that's an immune response to that particular disease, that is known as herd immunity. So herd immunity is the proportion of the immune population in that particular person. So particular population, the number of immune persons in that particular population is known as herd immunity. Okay, this herd immunity and herd effect are used in a pulse polio program. And recently, we are also using for another program. It has been recently given in your OP card 2022, 24, 23rd edition, 10th edition, and also it was launched in the year of 2017. 2017, yes, 2017, and in last date to implement this your West Bengal. Okay, in 2022, they implemented that program in West Bengal to all the children. So what I am talking about, which program is it? It is it's your measles rubella campaign. Initially, in your program, we had only measles injection. Now the measles rubella campaign, where all your hospital common setup, NIC, NIS, National Immunization Schedule, at 9 months to 15, you give MR, and another booster at the 15 to 18 months, MR booster one, and another is 24 months, you are a booster, right? Sorry, 24 nine after, yeah, it's our 24 months, 24 to 26 months. Okay, we will discuss that. So why this was given? MR vaccine, what the campaign? So in this campaign, so from any child between age of 9 months to 15 years, 9 months to 15 years, that is MR campaign. So what is a vaccine failure? What is a vaccine failure? Even despite giving vaccination, the child developed the disease, right? This is example primary and second. So what is primary? Primary is nothing but the child is unable to mount an immune response. Despite giving vaccination, unable unable to mount the immune response. That is primary vaccine failure. Its example is OPV. So someone asked me why the OPV is also it's a, it's also a cell-mediated immunity. OPV acts via your pair patch, and this pair patch most commonly is a pair patch is a lymphoid tissue. You will have T cell and B cells, and this B cells all get active, but it's a specific organ, right? It's only IgA specific. It's very regional one, and it doesn't have an equal amount of humoral antibody protection. So it activates your immunity in some way, but full full blown humoral immunity is not going to be activated by the oral poliovirus. That's the reason why the inactivated poliovirus came into the action. So this way, when you don't have an adequate amount of immune response, even you give a recommended dose. See, vaccine failures should be told only when your recommended dose is being given. If there are some area where the recommended dose is not given because of over dilution or under dilution, the dose is not a recommended one. Then, if the child is not able to mount an immune response or the child get disease even after the vaccine, then it is not said as vaccine failure. A recommended dose must be given. Even after giving a recommended dose, the child is not able to mount an immune response. It is your vaccine failure. That's primary vaccine failure. In secondary vaccine failure, despite mounting an immune response, the child is unable to get protected from the disease. The child is getting disease. You are giving a recommended dose. The child mount an immune response, but the disease still happen. Examples of diphtheria, DPT, BCG. BCG also have a secondary vaccine failure. So secondary vaccine failure, the child is producing an immune response, but the child is not. Uh, Child is mount an immune response, but the child is unable to get protected from the disease. So this is the vaccine failure. One is primary and secondary. Primary, there is no immune response, even giving a recommended dose. Secondly, recommended dose is being given, immune response is mounted, but the child is not being protected from the disease. These are the few examples. This is epidemiology. You already learned in your learned as already learned. So I am not going. This is eradication. So you have elimination. So what are the four things you have? Eradication, elimination, extinction, and control. So that you should learn in your book. This is already given in the book, so I'm not going to deal with it. So what about a vaccine that is live attenuated? What is a killed? What is toxic and subunit? So simple, live attenuated vaccines and killed vaccine. These two you should know. Live attenuated vaccine will produce infection, mount an immune response, but they never produce disease. Most of the time, they require only a single dose, no require of any multiple dose or any booster dose, because they produce an infection, they have immune response. So they have a memory B cells and whatever they want, they have. So they don't produce disease. But this chain can be affected. This is only possible if the child is immunocompetent. Very important, if the child is immunocompetent. If the child is an immunocompromised, for them or any high risk group, then they are more prone. Even by giving a live attenuator, immune response will be produced, the infection happen, but they are also prone for getting disease. So that's the reason why any active immunocompromised state or any immunocompromised immunosuppression state, live vaccination are not advisable. The reason is simple. Because in a immunocompromised children, they are not only getting the infection, and also they also have an immune response. They can mount an immune response. Sorry, in immunocompromised or in immunosuppression state, their ability of immunity is good, but they cannot mount the immunity. As a result, they go for the infection, go for the disease process. Whereas in an immunocompromised patient, because of active immunocompromises, because of primary immunocompromise or secondary immunocompromise, immunodeficiency state, they don't have an immunity, they have no state of producing that immune response. As a result, what happens? This infection will turn into disease because there is no gateway to control that infection, to control that particular infection. So in immunocompromised state and immunosuppression, immunocompromised because of your primary immunodeficiency and immunosuppression by drug, you don't give any live attenuated vaccine. Instead, we prefer a killed one. But if you're giving a killed vaccine, the killed vaccine will produce an immune response, but no infection. For producing this immune response without infection, you have to give a multiple dose. But no booster doses are advised. In no booster dose. Most of the killed vaccine doesn't require booster dose, but in IAP schedule, some killed vaccine they advise booster dose for a persistent of the immunity, for producing that seroprotection titer for a prolonged time. In that scenario, we give killed vaccine booster dose, or in a high risk population who are more prone, endemicity, more prone for that particular infection, then we give a booster dose in kill vaccine. But most of the time, we don't go, multiple doses required, but booster dose is not required. Booster dose are advisable in some situation. The booster dose in kill vaccine is been advised in special situation. About the toxide, in toxide and subunit, in toxide, what we are going, we are just using a part of that particular bacteria or any other thing. We give antigen or antibody, antigen of that particular. We are combining with some protein components like your proteins, so that or like aluminum, as you know, there are many things, salt. So this will increase the immunogenicity. per se, the antigen has no that particular immunogenicity. We're adding adjuvants. This adjuvants will increase the immunogenicity. When you give isolated antigen, that they will not produce a proper immunogenic response. But when you combine with some like your aluminum salt or any kind of protein substance units, then what it does, it will increase the immunogenicity. But for maintaining that immunity, you have to give a multiple dose to produce or mount an immune response. But for sustaining that immune response, you need a booster dose. So toxide also need a multiple dose to produce or mount an immune response. But uh, now I guess I will wait. Ipa கேக்குதா? Hello.
Yes, sir. Now it is audible.
Okay. See. Toxide. So now I'm talking about the toxide. So what about the toxide? Toxide also require a multiple dose for producing that immune response. But to maintain, to sustain that immune response, to keep it in a seroprotection state, you require multiple booster dose. The booster dose is important in a toxide. Example, so DPD, we give a DPD tetanus. Tetanus, you give immunization. We're giving a multiple dose. But after that, you need every 10 years, you give a tetanus toxide. TT injection is given every 10 years because to sustain, because it will, as per the literature, as per the, it's been saying that it will by 10 years, 8 to 10 years, maximum the stage for 8 to 10 years, then you have to toxin. This is the toxin. What about the subunit? It's an antibody or recombinant with some recombinant DNA technology, maybe viral vectors like that. That is your subunit. In subunit, we have polysaccharide as well as a conjugate. Okay, now the important, another important question to differentiate between the polysaccharide. What is the importance of polysaccharide? What is the importance of conjugate, polyconjugate vaccine? So that is your next slide. Now, so this is a table I took from OPGI 10th edition, right? Yes. Now, this is a table which separate, compare subunit your polysaccharide and conjugate vaccine. So polysaccharide is nothing but it's just that carbohydrate, the capsule, the antigen, without any other thing. Only you are giving a carbohydrate person in the bacterial cell surface, that is the capsule. Now, this carbohydrate will mount your B cell, and this is thymic independent. But thymus is very important because this thymus T helper cell is important to mount a good amount of response for a memory. So memory production is always depend upon your thymic cell. So in order to produce a memory cells, okay, in order to produce a memory cells to produce your immunoglobulins highly specific for that particular, your thymus is very important. Since here directly the carbohydrate of the capsule of that particular bacteria is involved, we directly stimulate your B cells. These B cells are not going to produce a memory amount of cell because the thymus is not going to be involved. That is antibody titers types will be always IgM and the duration of protection is only brief. Age at least should be given only after 2 years. Because less than 2 years, the children can mount an adequate amount of immune antibodies. After 2 years only, that system get adapted and they can prepare 2 years. So any polysaccharide vaccine is not in cannot be given before the age of 2 years. After age of 2 years, you can give the polysaccharide because B cells get matured and they can mount an adequate amount of immunoglobulin on their own without the help of T helper cell is always after 2 years, not less than 2 years. After less than 2 years, the B cell depend upon your thymus. The thymus produces T cells and B T cells. Mostly your T cells are mostly producing the thymus, but B cell to produce an adequate amount of immunoglobulin, it depends upon the T helper cell. And the T helper cell, the T cells are more produced from your thymus. So B and T cell involvement is more commonly seen in your less than 2 years. So if it happens less than 2 years, right? If it's a less than 2 years, then polysaccharide vaccine is not advisable. After 2 years, we are advisable. And the response accelerated by the booster dose or repeated dose is 4 because there is no memory cells. Got it? Memory cells are not produced. IgM cells are not going to live a short step. The memory B cells is always important to produce an important level, that's IgG. So IgG always important for your secondary exposure, which is not produced in your polysaccharide vaccine. In conjugate vaccine, here the polysaccharide is same, but I'm adding something very important, the carrier protein. Now, this carrier protein will make this vaccine more immunogenic. Right? Now, this immunogenicity, more immunogenic, so it will act by antigen presenting cell. This antigen presenting cell will act the T cells. Now, the T cells will act on the B cells, and they will produce more of your plasma cells and your memory cells. Got it? Now this T cells. So T cells and B cells are both get activated. So both B and T cell, and it's the time is dependent. So both IgM and IgG are producing, right? And now this is the I immunogenicity because both IgM and IgG, as I say, IgG production is very important for making more immunogenicity. That is one thing. And second, IgG will protect from a re-exposure. You have a repeated dose re-exposure, they will help you a lot. So they last, the duration longs last are inconsistent, and it is effective even after 6 months of age. After 6 months, you can give because your T cells is also involved. Your time is dependent. So after 6 months, also from of age, you can go for conjugated vaccine. Before less than 6 months, why the vaccine are not introduced? Your subunit vaccine, polysaccharide vaccine, and conjugated vaccine are not given below 6 months. What is the reason? Why? Anyway, why it is most of the vaccines we are called polysaccharide and conjugated vaccines are not given below 6 months? Anyone? Because the first 6 months, the baby are protected from all the kind of infection except for few for which we are giving vaccine. It's as per the schedule, immunity for making training your immunity also we are giving vaccine. But most of the vaccine are started for after 6 months only. What are they? The reason is your maternal antibodies. Your maternal antibodies protects the child till 6 months of age. Even though you can give these vaccines, but the point is the seroconversion rate and the seroprotection titer will not be achievable. The simple reason is because the antibodies that is produced by the mother is been transferred to the child. Now this antibody will protect passively. Now the immune system is developing. One thing, the immune system has not been developed. So another thing, you have a passive immunity from the mother. So immune system, even though they will not get trained for 6 months, and the vaccine which we are giving before 6 months helps in the training of that particular stuff. And the third thing is this polysaccharide and conjugate vaccine. When you give the antibodies, that is maternal antibodies, interferes with the antigenic response. One is your immune system is not that much well developed. Second thing, this maternal antibody will interfere with the antigenic response, so the required seroconversion or the seroprotection titer cannot be achieved. As a result, below 6 months, we don't give any polysaccharide and conjugate vaccine. It has to be given after 6 months. And most of the vaccine also likes act on that. So this is about the conjugate and polysaccharide vaccine. So what about the principle of vaccine? This is important. This was one of the 10 more question. What is the principle of vaccination? So it's already discussed. So I will be just clearing. See, you can give different live vaccine. So different live vaccine, it will be oral, parenteral, international. It can be given simultaneously or 4 weeks apart. different type of inactivated subordinate vaccine can be administered simultaneously or at any interval between the doses. So this is the concept. So any live vaccine, different live vaccine can be given simultaneously or at the interval of 4 weeks. Different type of inactivated or subunit vaccine may be administered simultaneously or at the interval between the dose. There are two exceptions which I will discuss while dealing with that particular vaccine. And if you're giving a vaccine, same vaccine, the interval should be 4 weeks because the 4 weeks which should be given between the two doses of same vaccine adequate for an adequate immune response. The body takes minimum 28 days, 21 to 28 days to mount an adequate immune response. So you have to give a space. So for that, so before any two vaccine, so schedule is like that only. Before any two vaccine, at least a minimum 4 weeks has to be given. But if you go two types of vaccine, what is the two types? Killed vaccine, toxide, oral, uh, inactivated, live vaccine, toxide. There is no recommended that you have to give live vaccine today. 2 days back, after only you have to give inactivated vaccine. Like there is no rule in that. So that's the reason a live and inactivated vaccine can be given administered simultaneously or at any interval of time. So you can give simultaneously also or at any interval of time. When you are giving two vaccine, mind you, if you are giving two vaccine and you are giving the same link, you are giving the same location, then the space between the two things should be 1 inch apart. Two vaccine, the activator or inactivator, whatever be the type, you are giving in the same limb. And say, for example, anterolateral, left anterolateral of the thigh, you have to maintain a distance of 1 inch apart, then only you have to give the 2 inches. Any lapse of the vaccine, if the child is now vaccinated, the schedule is today, but the child is coming after 1 week, you can give the dose. There is no arm delay. So they are giving the another important thing is delay or lapse of administration dose does not require the schedule to be repeated. You can give it the booster dose even afterward. Your schedule you cannot change the schedule. The schedule will remain the same how it goes. Okay. The protocol is you should not give before the time 4 weeks. If you have the minimum interval between the two vaccine, same vaccine should be 4 weeks. You cannot give before 4 weeks because the immune response cannot be mounted. Adequate immune response cannot be achieved. That is it. And if you cannot give an earlier the vaccine, that's the reason you cannot give earlier. That is the point given here. Vaccine should not be given earlier than indicator or with short interval between doses, then indicated in the routine immunization. The maximum dose is if the age is 2.5 months, you have to give. 2.5 months, 2 months, 15 days. You can at least the child should be 2 months, 10 days more. That is minimum 4 days gap. You can we can wait. If the child come here 2 months, 11 days, but as per recommendation, it's 2 months, 15 days. But you have to see other aspect of the things also because immunization is a national right and other parameters should be checked like whether the child, the like financial status of the parents, about the from where their location, how many the distance between the vaccination center and their location, and their socioeconomic status, everything should be taken care of. So if the child comes at the age of 2 months, 11 days, and everything is fine, then you can give because as per the schedule, as per the IAP schedule and IAP recommendation, minimum 4 days plus or minus is okay. After 4 days or post the age, you can give the vaccination. That's not a problem. But minimum 4 weeks gap must be there. Another thing, after vaccination, at least 15 to 20 minutes, you have to watch the child for any adverse effect following immunization. Another thing, immunization is not contraindicated in minor illness, prematurity, allergies, malnutrition, or during infection and antibiotic therapy. Wherever live vaccine are contraindicated, they are contrary inherited or acquired immunodeficiency, and during therapy with immunosuppressive drugs, I'll talk in a special situation. Immunoglobulin. See, this is other important tactic. When you are giving an immunoglobulin, this immunoglobulins will interfere with your live vaccine. One of the major live vaccine, MMR vaccine. This MMR vaccine should be given after how many long? 9 months. Whenever an IVIG has been given, immunoglobulin has been given, it interferes with the viral live vaccine for 9 to 12 months. So we always advise to give after 9 months because the B cells action, B cells status is been impact. It will not be a well good B cell response will be achieved after giving an one dose of IVIG. So at least 9 months should be wait before giving IVIG for MMR. But you can give OPV oral typhoid vaccine. And yeah, inactivating vaccine that is no role, but MMR, IVIG. If you give an IVIG, at least 9 months you should wait before giving the MMR vaccine. Passive and active vaccination can be given simultaneously. For example, your rabies, category 3 rabies, what you do? You give an injection, right? You give an injection. Yes. You give rabies vaccine and you also give rabies immunoglobulin. It could be immune or it could be acquired or it could be human, but you give both simultaneously so that you to confer the immunity. So these are the principles of vaccination. It is given in OP Guide 10th edition or other edition. Go through it because this point should be given in your schedule. Should be told in your exam as well, write in your exam. All these points are important. Okay, these are the national immunization schedule. You have to memorize it. There is no other go. So what are the things I have tell you? What are the vaccine schedule you should draw at the birth? What you give at birth, everything is normal. Everything is same. You give a BCG. You give an bivalent OPV and HBOV 0. What is this HPV 0? HBV 01 hepatitis B vaccine. Zero dose. What is zero dose? So I will see who will answer this. Why it is known as zero dose? What is zero dose? Why it is known as zero dose? It should be zero. I will see who will answer in chat box. I will see. Next, 6 and 10, 14 weeks, we carry the same thing. DOPV 1, DOPV 2, DOPV 3, that dose. And we give rota vaccine also 6, 10, 14 weeks. Fractional IPV, yeah, given at birth, but why the name is zero dose? You see, in IAP share, it's known as HBV1, right? We count that dose. But in our national immunization schedule, we don't count it. We tell it as zero dose. What is the importance of this? Why it is known as zero dose? So let's see who say that. That's the reason. What is the zero dose? Because we count this vaccine in your IAP schedule, but not in your NIS. There is a particular reason for that. So fractional IPV 1 and 2. We will give us 6 and 14 weeks. And PCV is given at 6 and 14 weeks. Pentavalent is given on 6, 10, 14 weeks. Right? Now the thing is, what difference in 6, 10, 14 weeks between your national immunization schedule and the Indian Academy of Pediatrics is you give the pentavalent contain what? Pentavalent contain DTP, influenza, hepatitis B. Okay. Which we give a pentavalent 1 and 2 and 3. A company is that. Here they are giving different, but they are giving separately. But the point is combining a pentavalent and combining this three vaccine into one is complaint because the patient will take this one and if you multiple needle stick will not be happen because you're giving DTP again, hepatitis B vaccine, influenza vaccine, IPV one, rota one, and PCV one. So what happened here? Yes, this thing multiple injections should be given, so the child will try to become fuzzy. So it will mainly point is more the child will have more pain. Instead of that, we have combined all these three into one and pentavalent we are giving. So what is a drastic striking difference between the National Immunization Schedule and IAP schedule is you don't give oral polio vaccine. See, in Indian Academy of Pediatrics schedule, there is no OPV. A simple OPV because the IPV play an important. IPV itself can take care of that OPV. The second thing, OPV is not given. The reason is the what? It can cause vaccine associated paralytic polio and vaccine derived paralytic polio virus. So with VDPV and VAP, this will not happen in your VAP and VDPV doesn't happen in your IPV, whereas it happens in a bivalent for oral polio virus. That is the reason why don't we give. But there's another indication which I will tell you. And so these are the thing. And another thing, IPV is given. We give fractional IPV in our national immunization schedule, whereas here we give three intramuscular. What fraction is intradermal? Fractional IPV is intradermal, whereas your IPV 1, 2, and 3 we give 6 and 14 weeks in your Indian Academy of Pediatrics. Which you give anyone give us it's a IM and Rota 1 and 2 3 is both common both same side. PCV 1 and 3. PCV 1 and 2, we give polysaccharide conjugate vaccine. Pneumonia conjugate has 6 and 10, 14 weeks. And another PCV 1, 2, 3, and we are giving in 6, 6, 10, 14 weeks. Right? Polyconjugate vaccine. Conjugate vaccine 1, 2, and 3. 1 and 2, we give 6 and 14 weeks in National Immunization Schedule. IAP schedule, we give PCV 1, 2, 3. And schedules, just the reason why I took this 6 and 14 weeks because to know what are the salient features difference between your National Immunization Schedule and Indian Academy of Pediatrics. That way you learn. By knowing the difference, you know that you can easily remember it. Okay. So machine intravenous is an important question. It was asked in your questions. So machine intravenous was with this program was started in the year of 2014 to with the target of covering more than fully immunized more than 90% of infants by 2020. By what is the strategy they use? They use the special immunization drives and intense efforts in focus area. Whereas intensified machine intradenosis, this was another program which come in the year after 4 years because when they introduce machine intradenosis, they introduce with 7 vaccines, vaccine preventable disease. That is the introduction. 7 color, 7 vaccines. That is OP, BCG, hepatitis B, DPT, IPV. 3, 4, 5, 6. So these are the things which they come in it is influenza B. So OPV, BCG, hepatitis B, DPT, IPV cover same. So you have 1, 2, 3, 4, 5, 6, 7. So 7 vaccine preventable disease they took in the action, and they told the objective was more than 90% of infants by 2020. After 4 years, again a program they intensified because they thought still even there is no one area that has not been covered with the vaccine. So they intensified the mission, and in this they strengthened with extra 5 more vaccines. What are they? Rota vaccine, Japanese encephalitis in endemic area, PCV that is a polyconjugate pneumococcal conjugate vaccine is a 1, 2, 3. Then we have Emma, measles rubella. That is 2017, right? 2007, measles rubella. So Rota vaccine, JE, PCV, and measles rubella. They all come in action in the machine intravenous IMI, that is your 2017. So extra, so totally 12 diseases have been covered. Here the point is to immunize more than 90% of newborn by December 2018. Here, newborns, we are carrying for newborns, not um, that's infant money less than 1 year. Newborn one with first 28 days to cover to immunize a child, and mainly that is vaccination on demand or to children more than or 5 years. This is the important thing which they took, and they accountability they have been improved. So non-health departments should also participate in this process. These are the things were taken, and what they did is they did a week-long immunization drive from 7th of each month. So every seventh day, for 1 week, there was a vaccine drive to cover all these 12 diseases. In 2019, IMA 2.0 here the motto was reach the unreached. So those people who have not been reached, should be covered. So identified areas were identified where the vaccine was not reached, and they were being targeted in the next campaign, that is 2.0. In IMI 3.0, this was introduced in the year of 2021. They again formulated reach the unreached with all available vaccine. And they covered the 250 IDs. This is importance for migrant population and hard to reach areas. Very way, I know it, but it has been asked as a 5 mark question. Mission Indradanos. So you should know the recent changes, because recent changes in the 3.0 and 4.0 has been added in the recent OP guide. And 4.0 was started in the year of 2022 February. Here the motto was reach the unvaccinated and partially vaccinated children less than 2 years and pregnant women and those who missed vaccination because of pandemic. Because in 2021 and 22, sorry, in 2020 and 21 we had a COVID pandemic. As a result, a lot of children missed their vaccination. To cover them, so this program IMA 4.0 came. So what is the outcome? Out of 701 districts who have been covered by the IMI, that is Inspired Mission Intravenous, full immunization coverage was seen in 6.7 in the first phase, whereas uh, your National Family Health Survey, which was done in 4 and 5, this 5 was done in the year of 21-22, and 4 was covered around 13, 14, I guess. I don't know the exact value. Between these two survey, the full immunization coverage increased amount the age year old of 12 to 23 months from 62% to 76.5%. So these are the main outcome by the machine intradrenal. So this is about the machine intradrenal. Now, so we will be talking about that every vaccine in not that much detail, but I will be sharing few important points for both your Viva as well as that. So Bacillus calmette guerin vaccine, that is your BCG vaccine. This is vaccine that is given at birth. So this is a birth dose. It is given intradermal 0.1 ml. So what is the strain? Now it should be interactive. So what is the strain we use for BCG? Anyone? What is the strain used for BCG vaccine? And where it is produced? We use Danish 1331 strain, right? Danish 1331 strain. Yes. Now, this is produced in our Gindi, Chennai. The only center in India which is approved to produce this strain is your Gindi. That is your Chennai, Tamil Nadu. So where you have to place, you have to give injection left upper arm at insertion of deltoid. In national program at birth you have to give. If it has been mixed, then up to 1 year you can do catch up. Whereas in IAP 2021, it is given at birth, same, but the catch-up is different. We can give up to 5 years. And what is about the BCG vaccine? So BCG vaccine, killed Danish 1331. Now, what is myco bovis, Mycobacterium bovis? Now, this will give your immune response. The immunity will be produced. What type of immune response it will give? It's a cell-mediated immune response. Why cell-mediated immune response? Why cell-mediated response? Why? Why cell-mediated? Anyone? Why the BCG vaccine is a cell-mediated response? What is important? Why I have to take on the cell-mediated, not immural mediated? Reason? Any guess? Why BCG is a cell? Why we target cell-mediated response? Why not B cell? Why not this? Why not your humoral cell? Because your tuberculosis is an what type of organism? Mycobacterium tuberculosis. Mycobacterium tuberculosis is what type of organism? It depends on what? It's an obligate, intracellular. It's aerobic, right? It's obligate aerobic intracellular organism. And this intracellular organism means what type of cell immunity, which immunity will take care of all intracellular organism? E cells, which is a cell-mediated immunity. Now, this cell-mediated immunity should be in target for your vaccine. So that's why the BCG is a cell-mediated. It play an important role in cell-mediated immunity. And after vaccination, what happens? At areas you will see there will be a pustule formation that will papule, vesicle pustule formation, then it will break off, then it form a scar. So BCG scar is very important, right? BCG scars form. So mostly with 4 to 8 weeks of vaccination, the papules and pustules will form. By 8 to 12 weeks, the blast it will ulcerate and it will form a BCG scar. This is very important. What does this signify? What type of immunity it is? Well, it takes 12 weeks to produce that all this effect for scar. It takes time. It's not immediate. The type for hypersensitivity reaction. Type for hypersensitivity reactions. That is your T cell mediator. So this is the reason. So what are the adverse reaction? Like see your local ulceration, discharging sinus. This local ulceration, accelerated adenitis is mainly because the reason is main. If instead of giving ID, you give IS. Sorry, intramuscular. Sorry, intramuscular subcutaneous. Instead of intradermal, if you give subcutaneous, then they will get this kind of reaction, axillary lymphadenitis and local ulceration. In immunodeficient, you should not give BCG because it causes disseminated infection, osteomyelitis, croflow. Contraindication is cellular immunodeficiency, symptomatic HIV, 2 to 8 degrees Celsius. What is it? Is your cold chain. You should know what is the way to know the cold chain. Discard any reconstituted vacuum maximum. You cannot use more than 4 years. So if you reconstitute, because cell lipid, it is a powder. BCG is a powder. So you have to reconstitute with the distilled water, a normal saline. Those are only two things. after reconstitution, you should use within 4 hours. If you use after 4 hours, what is the most common? What is the complication you expect if you use after 4 hours? Anything? If you give vaccine after reconstitution after 4 hours, what it can do? What is the dreadful complication we expect from that? One thing, when you stay after reconstitution, if you keep it for more than 4 hours, the chances of what? Chances of contamination by your bacteria, most likely your Staphylococcus aureus. Staphylococcus decontamination can happen. As a result, the child are more prone for toxic shock syndrome. So this is one of the adverse reaction which we will discuss in AEF5, which is the next slide. So in this way, while approaching, I will be just discussing with two or three vaccines because we have no much time. What are the important topics? I guess we will discuss that thing which have been asked in the exams, which we will discuss that. Other vaccine, please go through the. I will share the slide. Okay, so I will be discussing two or three more vaccine. Okay, then we'll be going to AEFI, another few important topic, and then we will close the class because I don't want to take much more time here. So, okay, so any vaccination when you go with, see, you see those route, site, schedule. At least please be prepared with your national program and adverse reaction, contraindications. Mm, and storage. Okay, cool. Okay, this is about the polio virus. So this is a bivalent oral polio, which the route I will just go with the route. This is 2 drops or 2 drops bivalent oral. As when you go for inactivated polio vaccine, as a fraction as plus your IM. When you go for IM, it is 0.5 ml. Whereas if you give intradermal, it's 0.1 ml. So know the route, know the program. In our setup or in your national immunization program, we give zero point 0.1 ml intradermal. Whereas for your in IAP schedule, we give IM, so it is 0.5 ml. Okay, same thing. So we'll discuss it next. So I don't want to waste time more. In learning of time, I'm not going to discuss much. So just I'm going to give the salient features for everything. DPT, this DPT is given intramuscular 0.5 ml. So in DPT, diphtheria contain amount is it's about 20 to 30 LF flocculation unit, limit of flocculation. Toxin, tetanus toxide is about 5 to 25 FL LF, and your whole pertussis is about 4 million, 4 million international units, right? So this as per the schedule, 6 to 14 weeks, and at 15 to 18 months and 5 years booster, and TD at 10 years and 16 years, and finally during pregnancy and every 10 years. If every 10 years schedule is followed in IAP, not in your national immunization program. And so catch up, we will see in the last slide I am discussing. Adverse reaction, very importantly for adverse reaction, local pain, swelling and fever. In rare, you see hypotonic, hyperresponsive episode. This is very important. Inconsolable cry, fever for more than 40.5 degrees Celsius, seizure, encephalopathy. Got it? So these are this reaction seen with both old pertussis and acellular. What is acellular pertussis? Acellular pertussis, we are not giving the old pertussis component. We are giving only two important antigen, that is pertoxin and FHA. Pertectin and FHA. Pertectin on FHA. This two are big in a acellulopertussis. So they are equally responsive: hypertonic, hyperresponsive episode, inconsolable cry, fever for more than 40.5, seizure, encephalopathy. What are the contraindications? Any previous anaphylaxis, encephalopathy within 7 days of previous dose, and progressive neurological disease, administration DT or TDMC. So whenever that's a progressive, for example, that's a question. If the child is having a neurodegenerative disease and CP, if a child is having neurodegenerative diseases, it is a progressive neurological defect. Where the diphtheria pertussis should not be given because they will cause encephalopathy and they will aggravate the disease process. Only TD, sorry, pertussis should not be given. Very sorry. Pertussis should not be given in that case. You give TD or DT. This can be given. And then CP. CP is a static encephalopathy, right? The static encephalopathy. This static encephalopathy, there is no progression of any neurological damage because already damage has occurred in a perinatal asphyxia has been done. So after that, there is no further neural damage. So in this case, you can give DTA or DPT. It's a contraindication here. Wait a minute. Okay. 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 So that's it. So these are the things which you should know. And other thing precautions are the same. So this DPT, because this is important, adverse reaction contraindication DPT is important because they have been asked twice in your university exam. And if you go for tetanus prophylaxis, you should know why the tetanus prophylaxis has to be given. Because as I said, the tetanus will not, the vaccine efficacy is not that much good. Because the reason is the tetanus, we don't have a human host. Okay, that's a result. You have to get repeated dose. If any dose, for example, if dose of TT received previously is important, if they are not received more less than 3 doses or that you don't know, that's no documented, and it's a clean minor wound, then give TT alone. That's known as of immunoglobulin. But if all other wound, both TT and TIG should be given. If they are already received 3 doses, but the age they are only after they are received 10 years back, then you have to give it TT, no need of TIG in case of clean minor wound. If all other wound, TT can be given, no TIG. If more than 3 doses has been received, but the duration of interval is 5 to 10 years. Like 5 years, less than 10 years, but more than 5 years it happened, then you can give TT in both clean and all other wound, but TIG is not required. But if the dose is given more than 3 doses has been given, 3 or more doses, and the last dose was given, but it was less than 5 years, 5 years back, there's no need of giving any dose. So tetanus prophylaxis should be known. So someone and ask what is TD, DT? What is the difference? Why it is small is been become D? Why it is become D? Always less than 7 years, we prefer to give D tap, okay, DT, DT, WP. But after 7 years, we only give DT or DAP. Why not D, big D? What the D, small big D and small d significant? The big D differentiate giving the unit. It's about 20 to 30 LF, right? Whereas small d we give just 2 LF, just 2 LF. That is the importance of the difference. After 2 years, after 6 years, after 7 years, the immunogenicity of the diphtheria toxoid is not going to change. It remains the same. But the reactogenicity, when the reaction, the adverse reaction will be increased of the age of 7 years. As a result, Now the recommendation is that after 7 years, don't give big D, that is DTAP or DT. Instead of give TD or TDAP, because the dose is reduced so that the reactogenicity is reduced. So measles containing MMR vaccine, there's no much importance. So that it is given at 9 to 12 months, same. So everything is same. Only thing is the contraindication for MMR vaccine. The only thing is any recent infusion of immunoglobulin contained blood product. I say IVIG should not be because IVIG interfere with your B cell maturation, B cell immunity. So after 40, it takes at least 6 to 9 months for your B cell to recover after an IVIG, one dose of IVIG. So after 9 months only, you have to give a measles containing vaccine. Another thing, measles containing vaccine associated with varicella. This MMRV, we give in Indian schedule we give MR, IAP schedule we give MMR. Also in some schedule we have MMRV. V for stand for varicella. But this MMRV actually associated with febrile seizure. We predispose the children to get febrile seizure. As a result, it is says less than 2 years. Only MMR, MR should be used. MMRV, if we are going to use, it should be used only after 2 years in order to reduce the incidence of febrile conversion. Hepatitis B, the same, you know everything about it. That's no other thing I have to tell specifically. Hemophilus influenza B vaccine, the importance is, testing. This all in our program, we give along pentavalent vaccine with DTP and hepatitis B at the 6, 10, 14 weeks. Catch up. If we are giving separately Haemophilus B influenza vaccine at 7 to 12 months, if you are giving two dose at more than or equal 8 weeks interval, one booster at 12 to 18 months. If you are giving between 12 to 14 months of age, one dose and one booster at 15 to 18 months interval. 15 to 59 months, you only give one dose. After 5 years, only high risk population, which we discussed in the special situation. So contraindication only hypersensitive to dose. Now, every vaccine which you are going to read, if you remember the principles of immunization, when two live vaccine, when two subunit vaccine or inactivated vaccine, if you're giving both inactivated and live vaccine are together, so what is the interval between two that particular vaccine? If you're giving immunoglobulin and vaccine together, where have to be given? If you know that principle thoroughly, you can easily remember the vaccine schedule because based on the principle only, your vaccine schedule has been derived. Another thing, pneumococcal because pneumococcal conjugate vaccine and pneumococcal polysaccharide. I already told you about what is the difference between a conjugate and polysaccharide. This conjugate vaccine is more immunogenic because you are combining it with a protein. When it is combining with a protein, the immunogenicity of that particular antigen increases and it mount an important IgG and IgM response, that is both T and B cell. As a result, your immunogenicity will be improved, your immune response will be more, there will be titer of IgG and IgM, and they will respond to booster dose and they prevent the disease more aggressively rather than a polysaccharide vaccine. Same thing, we give a pneumococcal conjugate as a PCV, MCV, PCV at 6, 14 and 9 weeks. And IAP 2021 schedule we give after 6 weeks of age at the age of more than 4 weeks apart, one booster at 15 to 18 months. Where polysaccharide, when you see, it is not given for any child. If you are going to give any child, only in high risk category. What are the high risk category which I will be discussed? Any child who is an immunodeficient, not polysaccharide is not immunodeficient. Any child who have been born from hyposplenism. What are the hyposplenism condition? Functional hyposplenia is seen in uh, sickle cell anemia, sickle cell disease, and post splenectomy, before doing a splenectomy, hyposplenism condition, that condition, and then chronic liver disease, chronic pulmonary or cardiac disease. In all this order, high risk population. In that population, you have to give this pneumococcal conjugated or PSV. PPSV 23, that is a polysaccharide vaccine that is given only if the high risk is present and the child should be more than 2 years old. And I already explained why not before 2 years old. Okay. And as a catch here, when you give a PSV, if you give a child a PSV, so what's the schedule to give PPSV? That is very sacred. Minimum 8 weeks gap must be there before giving a polysaccharide vaccine. Okay, if your child is injected with a conjugate vaccine, the time interval between a conjugate vaccine and PPSV should be minimum 8 weeks. You cannot give soon after giving a PCV, that is polyconjugate vaccine. For pneumococcal conjugate vaccine and pneumococcal polysaccharide vaccine, the time interval should be at least 8 weeks. Rotavac, we in India we give only Rotavac. Only one strain is used. As per our schedule, we give 6, 10, 14 weeks, 5 drops per oral. National program catch up to 1 year. After that, there is no. And as per your IAP schedule, it is first dose should be given before 16 weeks and complete the schedule by 32 weeks. That is the important point. Contraindication, any past history of interception should not be given. And already discussed why interception happens because of vaccine. I already discussed in previous classes also. So I'm not going to detail here. Human papillomavirus vaccine. The important thing in human papillomavirus vaccine, please go with this Gardasil 9. The thing is, Cervaris 7 is not been, this is not going to, that is removed from our market in the year 2021, I guess. It is not been marketing in our Indian market. So you should know about the Gardasil 4 and 9. 4 we give 6, 11, 16, 18. 16 and 18. This is very because these are the cancer producing strain. And the schedule. Why I am stressing off? Anything important? Yes, NIS and IAP. Recently in 2023 end, they have this recommendation for 9 to 14 years, both boy and girls. Gender neutral immunization. What is the gender neutral immunization? Initially, they were telling that the Cervaris, Gardasil should be given in female, girl, child. This vaccine is being given. But now NIS and IAP, I guess in IAP they have given recommendation in 2023. Hello, Kekrala? Hello.
Hi, sir. In the middle, few words were missing, sir. Like network error நினைக்கிறேன். Now it's fine.
முன்னாடியா இல்ல இப்பயா லைக் ரீசெண்டா இந்த
Just
கிளாஸ் இல்ல
just uh,
முன்னாடில
just
இருந்து
10
அப்படியே
seconds.
வருதா?
Just 10 seconds before, sir.
ஓகே 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 சரி நான் இப்ப பாத்துக்கிறேன். Okay, so now what the as per the recent guideline change, okay, recent 2023 of your IAP guideline, they have said that this should be given both for 9 to 14 years, both for both boys and girls. The schedule given two dose at the age of 6 at 0 and 6 to 12 month interval. Okay, so it actually given a 0.5 ml intramuscular upper delta. So this is the thing for your human papillomavirus vaccine as previously, but this is given now weightage because this recently IAP has given this should be a gender neutral vaccination for both male and female at the age of 9 to 14 weeks, 14 years at 0 at the dose, and after another second dose should be given at 6 to 12 months interval. This is not the optional vaccine, which is another 5 mark question which have been asked in your one of the supplementary exam. What are the optional vaccine you can tell? You give typhoid, varicella, influenza, hepatitis A, meningococcal, and yellow virus. They are the optional vaccine. Please go through the schedule that is being given in the chapter. This is only the tabular form. That is more than enough. Don't go with the theory paragraph. These are the optional vaccine. At least you should know the oral typhoid vaccine. That this oral typhoid vaccine and oral live meningococcal vaccine, I guess. No, influenza live vaccine. The live oral typhoid, we give TYP 21A. Okay, I'll say this only. This is important. Live attenuated 21A. This is oral capsule form. It is given after the age of the five years, 3 doses should be given every 3 years. Okay. But with what we have typhoid conjugate vaccine, 0.5 ml IM, which is given 1 dose after 6 months of age. There's no need of booster dose. And 1 dose should be, catch up can be given 1 dose up to 18 years of age. Live attenuated T by 21A because this is given orally. So they can ask this question because since this is an exception, this may be a question in your expected question in your university. Another thing, Japanese B vaccine is also given in your question. And we are using this live attenuated cell culture derived SA 1414-2 0.5 ml subcutaneous vaccine only in endemic area at 9. Another one is at 18 months. You can give. Initially, we give a neurovirulent vaccine that is Benjamin Beijing vaccine, which is now been taken Nagayama strain, which have been removed because of neurovirulent. We only go with this live attenuated vaccine, which I have previously discussed. And this is varicella vaccine. Varicella vaccine has nothing much to do. Okay. Okay. This is also not that much important. I got influenza vaccine. When you go for influenza vaccine, annual influenza vaccines are given all chronic patient or was plenectomy patient, chronic pulmonary or heart disease patient, or old age who are more prone for the influenza infections. So this has been an optional vaccine. It's been given an IAP schedule as a schedule IAP may have. Uh, that is an IAP schedule. But why I'm stressing on this live attenuated vaccine because it is given intranasally, 0.25 ml in each nostril, spray device. All LD children between the age of 2 to 18 years. First time vaccination, 2 to 9 year old, you give 2 doses 4 weeks apart. If the child age is more than 9 years, only single dose is required. And subsequently, if you give before rainy season, because in our country, before rainy season, pre-monsoon, in rainy season only, this influenza spreads. So in North India, it should be given during the June, and in South India, it should be given during the September. And what strain you are expected in India is a South Hemisphere strain. So our vaccine uh, helps and protects against the South Hemisphere strain. So the reason is important. If you're going to any America areas where the North Hemisphere strains are more common, but in our country we use a South Hemisphere strain, and the dose, as I said, should be given. Uh, I guess the only few slides more. Meningococcal vaccine, okay. Hepatitis A vaccine, okay. The last topic which I will cover, and then I will be discussing these two topics only. Then I will stop the thing. And because this is very important one, because it has been asked twice in your university exam as a 10-mark question. And if anyone who have covered it in your community medicine per se as a whole, then I guess it is more than enough. If you know the concept of community medicine, then you can write this essay, because most of the time this has been asked in essay as in community medicine. So any untoward medical event that follows immunization is known as adverse effect following immunization. What are the 5 causes because of that? One is your vaccine induced. Another is a vaccine potentiated, injection-related reaction, program of immunization error, or coincident. The coincidence is very less likely. Vaccine-induced anaphylaxis because of measles vaccine, VAP because of polio, PCC, adenitis, pertussis, encephalitis. This is because of vaccine. This is vaccine-induced. Whereas vaccine potentiated, the reason is what is differentiated with vaccine-induced and versus vaccine potentiated. Vaccine induced, the reaction is because of vaccine. The vaccine has caused the reaction. Whereas vaccine potentiated, the event has occurred following immunization, but the vaccine is not the cause of the immunization. Even if you don't give the vaccine, the child may have this reaction afterward also. The vaccine just, what you say, the vaccine has just escalated the reaction. Even without vaccine, the child may tend to get that particular type of event. That is your febrile seizure, which is more common. First febrile seizure after vaccine is a vaccine potentiated. It's not related with the vaccine per se. It is because of the escalation, because that age is a peak age for that particular condition. Like febrile seizures peak between 6 months to 6 years of age, and during that we give more commonly vaccine, and sometimes it get related with it. So this is vaccine potentiated. Injection reaction, pain due to reaction, pain due to injection, vagal shock. This is more is associated with your human papilloma virus injection, because they are co-finded it with all girls shall get like this kind of vagal response after HPV vaccine. Okay. Program awareness, vaccine preparation, and handling problem. So what about while you're preparing it? Coincidental AG of MMR. So this is important program when you this is the important whatever I said reconstitution. When you are reconstituting, and you should use within, there are few vaccines you should use within 30 minutes. There are few vaccines which you should within 4 hours. The reason is because they get contaminated easily. And when you give this contaminated injection, they will are prone for getting the toxidrome like staphylococcal toxic shock syndromes. So, what is the considered serious in the AFI is recipient death, hospitalization for the same, persistent and significant disability, and occurrence of cases in cluster. That is more than 2 cases. So, as a reconstituent, they should be once reconstituent, you should use in ice pack, and you should use within stipulated time, whether it's either 30 minutes for few vaccine, and for the few vaccine we should use within 4 hours. Example, Staph aureus causes the TSS and abscess. Okay. So disorder thing, what are the provoking? If they are allergic to egg protein, you should have a caution. You should not give yellow fever, measles, MMR, rabies, influenza. If they are allergic to gelatin, be very cautious while giving influenza, measles, MMR, rabies, varicella, season, toxin, Tdap, Saccharomyces cerevisiae, hepatitis B, and human papillomavirus. So disorder something, I will share it in the slide. Serious adverse reaction following any vaccine. One is anaphylaxis, adverse effects which we read in every topic. Any serious or unusual events, any sequelae of reportable events. If they are serious reaction following any vaccine. Reportable to particular vaccine specific. One is oral polio. We have paralytic polio vaccine strain polio, and then paralytic polio or vaccine strain polio. That is your strain 2 of your polio vaccine. Measles, 7 to 30 days. Measles in immunocompromised in case of six less than if you give an immunocompromised patient a measles vaccine, they will develop within 6 months. If they are developing within 6 months, then that's a reportable one, and they are getting a okay MMR, encephalopathy or encephalitis less than 15 days, tetanus, brachial adenitis within 28 days of vaccine. What is this? Encephalopathy or encephalitis less than 7 days. Rotavirus, interception within 3 days, 30 days, sorry. Rubella, chronic arthritis within 6 weeks. If these are the events that is associated with this specific vaccine, then you have to report this. Okay, so this is, we are done with this. I'm going to the last thing. And last is catch-up vaccine. So we'll complete it and we will discuss important questions. What are the okay? So if any child who's having a primary or secondary immunodeficiency, never ever give live vaccine. Live vaccine is contraindicated. Else you can give field vaccine, toxoid, or subunit vaccine. Live vaccine can be given if they have isolated immunodeficiency like selective IgA deficiency, or else any neutrophil and phagocytic defect. You may consider to give live vaccine. In HIV positive children, if mother's HIV status is unknown or indeterminate, live vaccine can be given. Negative or indeterminate. If HIV status of the mother is positive, then no live vaccine should be given. You can give all the, you should not give OPV, instead you give IPV. BCG should not be given. Okay, no live vaccine is indicated. In any immunosuppression case, I will discuss in the following slide what are the immunosuppression and what are the things. In any chronic diseases, you have to give hepatitis B, hepatitis A, influenza vaccine. More likely, influenza should be what? Yes, in a chronic pulmonary and heart diseases patient. And it is chronic liver disease, you should know have an hepatitis B and hepatitis A vaccine. Chronic liver disease. Splenectomy, post pre-splenectomy, they should receive meningococcal, pneumococcal, and what are the vaccine they should receive? Meningococcal, pneumococcal, what are the vaccine they should receive? Anyone? They should receive meningococcal, they should receive pneumococcal. What are the infections that are more common? Pneumococcal and meningococcal vaccine. And I guess I shall not remembering. And post infection, that is post vaccination, post splenectomy, they should have annual varicella and annual varicella and annual influenza vaccine should be the same, right? Annual influenza vaccine. All right, it is available. Achha, hemophilia B, sorry, this is the meningococcal, pneumococcal, hemophilus influenza B, and post splenectomy, annual influenza vaccine and varicella vaccine should be given. So last slide of this class is this. Please remember this. The vaccination of previously unimmunized child. Catch-up vaccination, for that I will make a table and give you. But for any case, another thing, each and every vaccine table, they are given the particular aspect, the catch-up vaccination. From there, you can make a note and then you can revise it. For simplicity, vaccination of a previously unimmunized child, I already shared it in your group. If the child age is less than 7 years, at the evaluation, give a BCG, oral polio, DTWP or DTaP, and hepatitis B. At the 1 month after the first vaccine, give oral polio, DTP, DTP and DTaP, hepatitis B. At 2 months, you give oral polio, measles containing vaccine, and typhoid. At 6 months, you give DTaP and DTP or and hepatitis B. This is for more less than or equal to 7 years. If the child age is more than 7 years, there is no need of BCG and polio. You go for DTaP and hepatitis B. At 1 month, DTaP, pertussis component is not needed. After 1 month, you give DT and hepatitis B. At 2 months, you give MMR or MR, typhoid. At 6 months, you give DT and hepatitis. In immunosuppression, if the child is on corticosteroid, oral prednisolone, this is for oral prednisolone for more than 2 weeks, live vaccine should not be given till 4 weeks. After 4 weeks of stopping corticosteroid, you can give live vaccine. If the child is on chemotherapy, after 6 months, only you have to give this. Irradiation and immunosuppression after 3 months. If the child is received any rituximab and IVIG, I already told, at least 9 months you should wait before giving the live vaccine. So these are the topic which is very important. I covered. There are a few things like vaccine vial monitor and shake test. That's very simple. If you read it, if any doubt, you can ask me. And there are passive immunization, which separate table as given in OP guide. OP guide. Okay. Okay. So any doubts? So I guess there are a few doubts. What about the few doubts you will ask? I will just telling that. One doubt is what is fulguration means. See, fulguration is nothing but fulguration is by using cautery. You have seen any OTs? I guess everyone has gone to operation theater. You have seen surgery. If you do when the surgery, they use cautery, right? While they open up the muscle layer, they use this cautery to remove, and then you see the smell. While doing cautery, you will have this eating, and there will be a eating, and there will be a production of that waves, that heat wave, and you will see the smell, not smell. You will see that smoke, right? That smoking. That process is known as denaturation, and that same thing when you do inside, do we that fulguration. That's a cautery. While doing the cauterization of that muscle, when they open up the muscle, they use this cautery to open up. While they open up the while doing that, what happened? That layer splits because of burning and the denaturation of the protein, and you will have this kind of blackish color as well as the smoke. You will be seeing the same thing. That's the process. Same thing happens in the fulguration too. Oral polio, as I said, target cell mediated T cell, but also your humoral mediator. That's a humoral mediator for which you give IPV. Now, OPV has been obsoleted because there's chances of vaccine associated paralytic polio. That's why your immunization for painted patches get filtered, and it prevent the polio replications in intestine, so in intestine, and also it provides herd immunity, so it break the chain of transmission. Hmm. Okay, okay. So, so how to manage and quickly revise? Do you recommend any specific order of revising, considering that I read once already? For what? For this study for old pediatrics, or talking about immunization? Be specific for that. For immunization, it's better make a table. Okay, either be specific with either one thing, either with IAP or else NIS. I will recommend go with NIS, National Immunization, because this is the thing which we are following all the hospital, government hospitals. So go follow with your NIS, make a table, revise that table, catch up in recent book. Initially, there was no catch up points in your chart which was given in your old OP guys. In the 2021 OP, the recent 2023 OP guide, they have catch up uh, vaccination also in every table of your vaccine. So just take it for your catch up vaccination. That will be very helpful. Is it enough to read the systemic chapters from medicine in detail and just go through pages of see, yeah. See, there are few topics which are important. Like first, there are few in group also. Someone has told that first 10 chapter of OPGI you should read thoroughly, and then other chapters with the medicine you can cook it up. For me, yeah, if at last, so I didn't talk more than that. I didn't wanted to comment on that because during this time we have no time for to read the book entirely. Yeah, you can go with that also, but be sure there are a few topics which are very common to pediatric, not in adult. For example, your GERD. This GERD in infant, adult, is very quite different. So you should know the difference between each. If you know the difference, you have to modulate your answer. For your clinical feature will be different. Your diagnostics will be different. Treatment will be giving same thing only. You are going to, but in adult, they will go directly with what? They will go directly with drug, proton pump inhibitors, right? But in children, what we do, we start with lifestyle modification. There are also lifestyle, like smoking, they will reduce. But see, they will see of spicy food, they will avoid spicy food, don't eat over beverages, and then PPI. But in children, apart from children will not smoke, so we'll what the problem? Passive smoking. So we will avoid passive smoking. We will tell. We'll see any home what type of fuel they are using. So we'll avoid that type of fuel. Coal should not be used, or passive smoking should be avoided. Pollution should be avoided. And second most important thing, feed. Spicy food they are not going to eat, but thickening of the feed. We will thicken the feed. How we will thicken it? We will add some extra calories, or we will make rice here, or we will make some thickening of the feed. This thickening of feed will prevent a GERD in child. So these are the things which are different in children and adults. If you know that points, then you can go with your medicine also. Medicine points along with the children specific points. That's the important thing. There are a few conditions which are very common in children. As I said, that like your idiopathic hypertrophic pyloric stenosis, right? And like that, systemic factors. Another condition like your congenital heart diseases that you should read from pediatric only. So like that, there are a few specific topics which you have to read from the pediatric. So that you read, and then other topic which is very common in both pediatric medicine, you can go with medicine also. Okay. Yes, I guess these are the thing. So it was a long class. I guess around it took around it's about 2.5 hours. So I hope any doubts you can ask in the group. I will share the slides. Important thing, and you can ask the doubts in the WhatsApp group and Telegram group. Okay.
Thank you, sir. Thank you so much. It was again a wonderful session, sir. And I guess around 200 people, 225 people around have got benefited today. And around lots of people are seeing it after the session also. Hope the students, if you have any doubts, you can just post your doubts anytime in the group or in our chat box or in the comment section, so that sir will be answering it. Thank you, sir. Once again, thank you so much. Let's come back at another session, another wonderful session, and all the best for every student, those who are like preparing for your exam. Yeah, at any point of time, if you feel any difficulty, you can just put it in the our WhatsApp group, so that we will be available to answer your queries. Thank you, and thank you so much. Once again, I would like to thank Prithiviraj sir for joining with us in his busy schedule. Thank you so much, sir.
Thank you. Thank you. Thank you. Okay.